Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
Hi everyone, thanks a lot for listening in to this podcast by the Liver Foundation. Um, Today I have with me Dr. Elizabeth Aby. She's from the Department of Gastroenterology, Hepatology and Nutrition from the University of Minnesota in the United States. And she has recently authored an article that was published in Hepatology Communications, and it's entitled High Rifaxamin Out-of-Pocket Costs are associated with decreased treatment retention among patients with hepatic encephalopathy. For the rest of our discussion, and for brevity's sake, I think I'll refer to hepatic encephalopathy as HE from here on in this discussion. So thanks a lot, Dr. Aby, for joining us today. If I might just briefly kind of maybe set the stage a bit or kind of establish the background for this article. Can I ask how common is HE among patients with cirrhosis in the United States? Like, what's the burden of the problem, and what are some of the costs associated with the treatment of HE?
Yeah, great question. Great start. And thank you for inviting me to do this. So as we all know, hepatic encephalopathy is a devastating manifestation of cirrhosis for patients with liver disease. So it's manifested by changes in mental function and concentration, as we know. And then I think it's just important to understand the dichotomy also of the spectrum of disease, that there's covert and overt. And even the covert symptoms can cause sort of a disruption to the daily life of folks. And then also, before we even get into the prevalence, I think understanding that the natural history for folks with cirrhosis changes when folks develop hepatic encephalopathy. There's data that following the diagnosis of hepatic encephalopathy, that the median survival for folks with cirrhosis is shortened to 2 years, and then to 1 year for those who are over 65. So pretty significant complication, and it's fairly common. So hepatic encephalopathy occurs in up to 40% of patients with cirrhosis, and they suggest that it's about 27% in those with Child's A, and then about 60% in those with Child's C. So a little bit different based on the spectrum of cirrhosis, but overall, sort of as many as 40% of patients with cirrhosis. And then to your point of sort of burden of hepatic encephalopathy, the hospitalizations for folks with hepatic encephalopathy are increasing and are costly. And we know that data used from the National Inpatient Sample from 2010 to 2014 suggested that there was already a 25% increase in hospitalizations for hepatic encephalopathy. And then that subsequently leads to increased burden. So the estimated economic burden of hospitalizations related to hepatic encephalopathy in the US, at least, in 2014 was estimated to be almost $12 billion.
Wow.
And then, yes, and a recent study by Michael Volk and his team using 2 large private insurance databases found that the average cost for a hospital stay for hepatic encephalopathy was approximately $30,000. So not only is it costly to sort of healthcare quality of life, it's costly in terms of hospitalizations, and then readmissions multiply the burden of hospitalizations, and a lot of people with hepatic encephalopathy get readmitted. The thought is that it's about a 3-fold increase. The presence of hepatic encephalopathy increases liver-related admissions.
So I guess this, I think, sets us up very nicely to discuss the rest of your study, and I guess that's what kind of prompted your study as well. So maybe you can explain a little bit about how your study was designed, and I mean, why choose to study the out-of-pocket cost of rifaximin in particular, and how it affects, hospitalizations and the cost of HE hospitalizations.
Yeah, great question. I think part of it has been related to the folks that we see in clinic. I think it's often really discouraging when folks come in for a hospitalization or in a clinic visit and have covert or overt symptoms of hepatic encephalopathy, and you find out that the only reason that they were not taking their medication is they couldn't afford it, or the prior authorization didn't go through. And I think when you see that come into clinic or come into the hospital more and more, you realize that something sort of needs to be done in investigating sort of the impact of out-of-pocket cost and these barriers to rifaximin, because we know that rifaximin is beneficial for hepatic encephalopathy treatment, but sort of the drug cost remains a significant barrier. And so the study design and sort of what we were aiming to do was measuring the impact of out-of-pocket rifaximin drug costs on treatment retention. And I'll get into that a little bit later. We specifically studied commercially insured patients in the US, and that was just a factor of the type of database we were using. And so before I even go further, so out-of-pocket costs are expenses from medical care that aren't reimbursed by insurance. So that includes copay, co-insurance, and deductibles. So out-of-pocket costs matter because they can lead to significant stress or harm for our patients. And folks have to sort of, in the United States, sort of pick among a spectrum of types of insurance. And unfortunately, among the spectrum of care, there's things like high deductible plans, which are great options for some patients, but the monthly premium typically lower, so the monthly cost, but oftentimes those folks with a high deductible health plan will pay more healthcare costs when they need it. And the insurance company has sort of a higher deductible for sort of the things that they use. So that will come into play later. So when we think about how we designed this study, it was a retrospective cohort study. We looked over 10 years from 2011 to 2021. We use the IBM Market Scan database. It's really helpful because it has health insurance payment data for inpatient, outpatient, and outpatient pharmacy dispensing. So it has sort of across the spectrum of care. And the database itself has medical and prescription claims for insured employees and dependents from over 100 different insurance companies. So over 40 million folks in the US. And it's useful because it has a lot of sort of more granular data. So demographics, diagnoses, medication costs, and healthcare plan enrollment. So that's partially why we use the IBM Market Scan database. And we focused on adults who were newly diagnosed with hepatic encephalopathy and initiated on rifaximin and or lactulose within our study period and had at least 6 months of drug enrollment. So at least 6 months of insurance. And the primary outcome, what we were looking for was rifaximin retention on the impact of out-of-pocket cost on rifaximin retention. So now we'll get into sort of what that is. We defined rifaximin retention for the great majority of our study as greater than or equal to 80% of eligible days of rifaximin that folks were taking it. So that's the proportion of days covered. And so we use that looking at prescription fill dates and days supply, and sort of that 80% threshold is most commonly used for studies like this, looking at treatment retention.
Okay. So I think you've kind of really nicely described your study. I just had a few more kind of things I wanted to ask. I think you've already mentioned like stuff that I think our international listeners may not be so like familiar with in terms of out-of-pocket costs and the high deductible insurance plans. Can I just ask, because you mentioned also that you took the data from a database that of commercially insured patients. Would this then kind of maybe bias the data in a certain manner? Because I realized that non-insured patients are not included, and these are the ones actually who may have even more difficulty in terms of being able to afford these high cost medications. And the second thing I wanted to ask out of curiosity is, what would the kind of average cost of rifaximin be in the United States? Yeah.
Yes, so great questions. So first, to your point about not including folks who are uninsured, that's a huge issue in the United States, unfortunately, of how many folks are uninsured and thus sort of pay for everything that they need, typically out of pocket. There's other sort of social supports depending on where you live in the country and sort of what access you have to care. We heavily rely on our social workers to help folks apply for insurance, but Unlike other countries, it's not universal health care in the United States, unfortunately. And so certainly the barriers we're seeing and sort of demonstrating in this study are much worse in those who are uninsured. And there is a big pocket of patients in the US with cirrhosis who are uninsured. So that's an absolute sort of limitation of our study. And then in terms of the cost for patients, sort of for a 30-day supply, sort of the average cost for folks was around $30 to $50, but we saw some folks who were paying upwards of $1,000 for their
$1,000. Wow.
Yes, $1,000. And somehow, I think sometimes what is challenging for patients is they don't understand that there's other options. So they go to the pharmacy to pick up their med. They're told how much it is. They're told there's no other options for the management of hepatic encephalopathy after lactulose. It's the best sort of second drug after lactulose. And they don't want to have the fearful complications that impacts their quality of life. So they just pay it, which we have other sort of abilities to get folks help. We should have more, but it's wild that people pay that much.
Yeah, that's I think quite a large figure, and I think it's kind of sad that in this day and age there are still people paying this much amount of um money for like very important and essential medications. So maybe I'll just move on a bit to kind of discuss the results of your study. Would you be able to highlight some of the significant study results? And also, I think okay, maybe I'll get you to describe your significant study results, and then I'll ask you some questions based on these. Yeah.
Yeah, that sounds perfect. So we again looked at adult patients. We had about a little more than 6,000 in our whole study. A little over 4,000 were prescribed rifaximin. Most of the folks in our study were sort of older, between 55 and 64. The majority were male, and the great majority were living in urban settings. So sort of painting that picture as well. We looked at several different rifaximin treatment retention periods. So we looked at 180 days, 360 days, and 540 days. And even at the 180-day mark, the rifaximin retention rate was only 42%, and it decreased over time, as one would expect of sort of more barriers potentially over time. So it was 25% at 360 days, and then only 16% at 540 days. So first things first, we saw that rifaximin treatment retention was low and got even worse over time. And that for sort of those who were retained in treatment, who were more likely to take their meds, had a lower average 30-day out-of-pocket cost. So if you think about sort of median out-of-pocket cost, we talked a little bit about it. The median 30-day out-of-pocket cost for those who were taking their medications or retained on treatment was $35, where it was $40 for those who discontinued treatment. While this is sort of feels like a negligible difference, sort of over time, we then looked at sort of cut points. So we chose the cut points based on our data of $50 and $150 for 30-day out-of-pocket cost. And we found that those who had a 30-day out-of-pocket cost greater than $150, they were more likely to get discontinued treatment. And so sort of that 150 point also was sort of a signal for us that those folks were more likely to not take their medication.
Okay, so I think you mentioned, firstly that the treatment retention kind of decreased over time. What would be some of the reasons that treatment retention decreased over time? Would this be purely due to costs? I think patients with HE also, I'm not sure, because their mental state may not be, they may be confused, or, their compliance may be uncertain. So could it also be they have decreased compliance, or maybe decreased ability to pay because of decreased ability to find work?
Yes, I think cost is only one sort of factor in why folks are taking their medications. It's also thinking about access to how are they going to the pharmacy to get their medications? Who's driving them? If you have hepatic encephalopathy and you can't drive, you need a caregiver to go to the pharmacy and get you your medications. But if you don't have someone who can go and get your medications for you, Also sort of keeping track of all of your medications, knowing when to refill them. There's a lot of other barriers that impact sort of why folks take their medications or pick them up, or if they, for instance, don't feel like their medications are working for them. Why would you pick up a costly medication when you still feel as though you're confused or have sort of slowness to your memory?
Yeah, I think your study also mentioned that for patients who discontinued treatment, I think there's one that said that in the longer period of time, they were more likely to have insurance with a high deductible health plan. So I think that was where probably what you mentioned earlier in this discussion would kind of come into play, like maybe over a longer period of time, the costs build up and therefore, they are less likely to want to continue with the medication despite its benefits. The other thing I wanted to ask, I think you also, as part of one of the like secondary analysis, I think you kind of analyze the impact of rifaximin on hospitalization, and there was a recent study which you also referenced in your paper earlier in this discussion that kind of showed that rifaximin, or sorry, the rifaximin treatment adherence was actually associated with reduced hospitalization. But I think in your study, it seemed that they had longer hospitalization stay, but there was actually no difference in terms of the number of hospitalizations within the first like 6 months of treatment. And there was no kind of relationship between the 30-day out-of-pocket costs for rifaximin and all-cause hospitalizations or HE-related hospitalizations. So maybe I can just ask what do you think is the reason for these observations?
Yes, and so I think you put that really nicely. This was not sort of our original intention, and to give you some background, we did this analysis after reviewers sort of recommended we do so.
Okay.
And so we found that individuals who were more adherent to treatment were less likely to be hospitalized, but there were no significant relationships between out-of-pocket cost and readmission. And I think partly when you do any analysis looking at readmissions and out-of-pocket costs, there are so many cofactors that in terms of treatment adherence and costs that impact readmissions. And so I think when you have so many cofactors that are sort of part of the interplay of why folks get readmitted, something like out-of-pocket costs, while significant, sort of can get lost in the weeds when there are so many other reasons why folks are getting readmitted to the hospital.
So I guess the main message one of the main messages is that number one, obviously rifaximin, I mean, there's a decrease in treatment retention if the medication cost is expensive. But the second part, I think, is that for all studies related to medication adherence, because this is a really complex issue, there are many factors involved. So I mean, just moving on, how do you think? I mean, this is kind of just discussing some of the study results, and how do you think that your study results can, impact healthcare policy, or how do you hope that your study results can kind of help to make a difference in terms of changing policies?
I think a couple of things that we were hoping to sort of get folks to think about is, before even policy, is financial burden and financial toxicity of medications is significant for our patients. And so if we don't ask our patients, is cost impacting their treatment, then we won't know. So there's a lot of different sort of ways that we can assess for financial burden of medications. They're somewhat imperfect in the study of liver disease. There's something called facet cost that's used in the cancer literature that can be sort of a screening tool for financial burden. But I think in clinic, when folks are taking medications that are related to high out-of-pocket costs, or just in general, asking sort of the financial burdens to their treatment, accessing parking, paying for their medications, etc. So that's first things first, is if we know that financial issues are impacting our patients, we need to screen for it and sort of help engage social workers and our financial counselors for those patients. And then second thing is sort of physicians are sometimes involved in involved in policy, but getting more involved in policy decisions of sort of how do we help folks get access to medications that they need? Because over time, on the whole, we've shown from sort of our data in combination with other data that if we're keeping patients at home, higher quality of life, out of the hospital, that's better for society as a whole. And so getting sort of policymakers and clinicians to sort of engage in how do we get these costs for patients down?
Yeah, so these are excellent points actually. I think it's good to like kind of raise awareness on the fact that we need to engage our patients in terms of finding out if they can afford the medications. And I guess this would be a way for us to kind of improve treatment retention rates. In terms of using this study, do you have any other further like or do you think that this study can be a springboard or for further studies in this field, or is there any kind of future directions for research in this field that you would envision?
I think one thing that I think about is along the spectrum of care, either if it's general cirrhosis care or liver cancer screening, whatever it may be, having physicians think more through the process of what it takes for a patient to go through all of the steps that we ask them to. And so thinking about sort of switching to a different part of cirrhosis care, but HCC screening or liver cancer screening, say someone gets an ultrasound and they need a liver biopsy after that, or an ablation or something like that, thinking about the spectrum of care that we're asking our patients to do, and thinking about the different costs, whether it's to the patient, their caregiver, lost wages. I think the financial impact of end-stage liver disease is much more than I think we often think, and keeping those factors in mind when taking care of our patients is going to be incredibly important, because we can recommend all of the things that we want to, but if a patient can't afford or do the things, then it's not so useful.
Okay, so maybe last question, but maybe I'll switch away from the heavy like science questions, but maybe something more clinical. You mentioned earlier in our discussion that, for patients who may not be able to afford rifaximin, they go to the pharmacy and they realize they can't afford it and they don't know that there are other treatments available. If they are already on lactulose and they're clearing their bowels like at least 2 or 3 times a day as per the recommended guidelines, how else would you, and they are unable to afford rifaximin, how would you then manage this patient?
So first things first, I think it depends on sort of the institution where folks work at. I think we are very lucky where I am at to have financial counselors and social workers who are fantastic, who we reach out to them, we find sort of these loopholes or ways or grants to get them the medications that they need. Because there are certainly sort of secondary medications for hepatic encephalopathy. Ones can consider neomycin or zinc, and sort of the data behind those medications is so-so. But sort of working with the resources that you have at your institution if possible, and then potentially reaching out to the company to see if there's other ways that you can get sort of cost-reduced medications to your patient.
Okay, so thanks a lot for this interview, and please, I hope that our listeners enjoyed listening to us talk about the out-of-pocket cost of rifaximin in hepatic encephalopathy and how it affects our patients. So thanks a lot, and I'll see you at the next podcast.
We have come to the end of the episode. Thank you for joining us, and stay tuned for more captivating discussions.